everyone. So I'll go straight away, I go with the cases. The 62-year-old male, hypertensive diabetes, presented with angina and syncope. One episode of VTBF and DCL. And TRAPI elevated, and even the NT-proBNP is elevated, both. You see the angiogram, there is a significantly calcified LCX and LAD, even distal LM also involved. But the MLA is reasonably, that is about 6.8 square mm. So these are the IVA studies of the LCX and LAD. So you can see very clearly. And you can see the distal LM area is about 6.8 square mm, and remaining portion of the LM is uninvolved. Ostial L6 is 3 square mm, proximal L6 4.1. So then because of the significantly calcified L6 and LAD, we thought of doing orbital atherectomy. So we did the orbital atherectomy, that is 80,000 speed, crown speed is 80,000. Initially we did L6, LM to L6, the forward and subsequently followed by LAD. So whenever you use the orbital atherectomy, slow motion of the crown is very important, 1 mm per second. So if you are moving the crown very fast, the ablation capacity of the crown is very less. Say, like if you want like a 1,20,000, if you are moving fast, that is equivalent to 80,000 speed, slow speed. So that's the reason after orbital atherectomy, again we acquired the IVA studies. You can see the IVA shows the fracture, evidence of fracture. That means adequate plaque modification was done. So we were very sure that adequate plaque modification done. Then we went ahead with the DK crash. Initially, after orbital, again dilated LAD, that is ostial L6 2.75 into 15 onyx frontier, and simultaneously we kept 3 into 12 mm in LAD. And this is crushing. DK crush, when you do, always the side branch stenting, always pull back. The ostium has to be opened perfectly. So if adequate dilatation not there, then again take another NC dilated before crushing. Then it's easy to cross, results will be better. So again LCX studs were opened with 1.5 balloon, first kissing balloon, 3.5 NC in LAD, 2.75 NC in LCX, and LM to LAD 3.5 into 38 onyx frontier. The part was performed with 4.5 and second kissing at the same 3.5 and 3 balloons. Repart was done with the 4.5. This is the IVA study after stenting. You can see the distal LM 13 square mm, ostial LM 14.6 square mm, and ostial LAD 8.5. Very good areas. Distal edge of the middle LAD is 14.6 square mm and distal landing zone 9.6 square mm. So subsequently we acquired the even L6 IVA study. Ostial L6 we got 5.2 square mm. So proximal L6 5.9, distal edge 6.5. So distal landing zone area is 5.6 square mm. So this is the final angio view, then DK crash, orbital plaque modification. This is a case, you see the LAD diffusely diseased. Patient came with anterior STEMI, 2D echo regional wall motion abnormalities in LAD, severe LV dysfunction, and L6 also OM is diseased. LAD top to bottom severely diseased and relatively distally there is no flow, and RCA reasonably good, that is also disease. Then LMCA was engaged 7 French, EBU 3.5, run through was used, pre-dilated with 2.1. But distally we were unable to cross with the balloon. This is a balloon uncrossable lesion of the distal lesion. So then we took the 1.5 bar. That is 1,60,000 revolutions, 6 runs were carried out. So now distal lesion pre-dilated with the Riori, proximal 2.5. Post-rota, this is the IVA study. IVA study shows the thick calcium. Proximally, it's still, distally it's fine, but proximally the calcium thickness is more than 1 mm and arc is more than 270 degree. In some of the areas almost 1.2 thickness. So when 1.2 mm thickness is there, it is not, no matter what, it may not be going to yield with any NC balloon. So then what we thought, we see this is the analysis of the post-orbital analysis, post-rota analysis. Then IVUS study showed thick calcification. Then we used the IVL C2 plus 120 pulses were delivered to entire LAD. So this is the subsequently distal LAD. We use it because distally vessel is very small, tapered. We use 2 into 40 mm DEB at 6 atmosphere for 2 minutes using the guide plus support, and the proximal to mid LAD stented with 3.38 onyx frontier, austerior LM to LAD 3.5 into 30 onyx. And this is the post dilatation, the part of the LMA with 4.5 and the proximal LAD dilated with 3.5. Now this is a IVUS analysis. IVUS analysis shows a well expanded stent with a good luminal gain. LM shaft is 17 square mm, that is 4.5. So whenever you do the left M, always aim to get at least more than 10, because if you see the Excel study or Noble study, the sub-studies have shown very clearly the persons who achieve more than 13 square mm, they will have a better miss compared to those with less than 9 square mm. Though the Kang studies have shown very clearly the like a 7, 8, 7, 6, 5. But always aim for achieving the better MSA provided within the limits of the vessel size. So this is the final angio. You see nicely flowing LAD. And why onyx we prefer for these patients? That is dual flex balloon, more flexible because it's severely calcified, difficult to track, and because the thin profile and increased catheter flexibility compared to existing resolute onyx platform. As you are aware, it's a single wire platform and platinum iridium core with shell consists of cobalt chromium. And the Rolex study has clearly shown the safety of this stent. That is almost it constituted 53% patients with ACS, 30% with diabetes, and low TLF was noted. That is 5.1%, TLR is 2%, ST 1.1% at 1 year. So results are better even in diabetic with a small vessel disease, because when 2 mm stent was used for distal complex lesions, the almost TLR was noted in only 2% of the patients and with a 0% stent thrombosis. This is another case, 17-year-old hypertensive, hypothyroidic, ACS with evolved posterior wall MI, EF 61%, and usually the osteal LMC 30%, and diffuse disease of LAD. You can see the LCX also disease. So what we thought, we wanted to do the IVS guided PCI with the DK crush stenting with IAPP support and IVL. So this is the IVL of the LCX. Predilatation, IVS study, you can see very thick calcium and tight lesions, and you can see the IVL balloon 3 into 12, 120 pulses, mid to proximal, and subsequently angiosculp was used to do the further plaque modification, and 3 into 38 onyx frontier, LM to LAD, and this is the distal LM 9.8 square mm, austerior LCX, this is a LCX study. So subsequently LCX plaque modification was done with IVL balloon, and then then we went ahead with a DK crush as usual, like a first kissing, then opening these side branch studs and main vessel stenting, then subsequently second kissing, report. So while doing the part of the LMA, patient developed cardiac arrest because of diffuse disease. Then we did CPR, we picked only one at the end of the CPR, but after CPR, further procedure was continued, stabilized, and this is the IVUS study. Always prove with the IVUS that stent is expanded very well, but there is an under expansion of the distal edge of the stent. So then what we thought, we took the 3.5 into 20 mmNC to dilate it further. So final result was good with good antegrade flow. This is a final case. You see, this patient came to us with recurrent pulmonary edema, refractory cardiac failure. He was in the hospital for 7 days. We told the surgeon to go ahead with the surgery because of the sick status. He was reluctant to operate. Then we thought we will ask him to go and come back. But at that time I went to Euro PCR. But when after taking discharge, again because the acute pulmonary edema, he got admitted, again stayed in the hospital. Then what we did again we repeated the right coronary study, right coronary normal, but IVA study showed a very tight ostial left main, very tight ostial left main. Then there is significant block burden of the proximal LAD. This IVA study, and pre-dilated with 3.5 into 10 mm Wolverine, because more of fibrotic, there is no significant calcium. Then that's the reason we use the cutting balloon to dilate the ostial lesion of the LM as well as the LAD. And this is the study after a cutting balloon. You can see the ostial LM is about 6 square mm and ostial LAD 9 square mm, distal left main 5.4. That is a big left main. So because that, see, this is a post-cutting balloon IVA study. You can see very clearly. IVA's ostium also. This is the ostium of the, there is a thick block burden. Then LAD stenting was done with 3.5 to 30 mm onyx frontier. And proximally, left main to proximal LAD, we used 4.5 into 18 onyx frontier stent, LM to LAD, overlapping the proximal edge. This is the part. We used a 5 mm balloon to do the part of the left main. So this is the final analysis. The IVAS area, what we achieved the left main is 5 point, that is 21.3 square mm, and the area is about 5.2. It's a huge area. So stent got expanded without any distortion. That is the reason we wanted to focus this one. This is the final angiography result. So good antegrade flow of the LAD. So to conclude, it's a because the improved design is more useful for simple to complex coronary artery stents, more trackable, more flexible catheter, and rounded studs also easy to access the side branch. And because the almost the crossing profile is about 7.5% and catheter flexibility is about 29% compared to the earlier platform, because the single core wire technology, more flexible, more conformability, and apposition of the very well, because the iridium and platinum core technology, it is better visible compared to other stents. Thank you one and all for paying the attention.